Mid-tutorial presents hypertension. An elevation in blood pressure more than 130 over 90 mm of mercury is known as hypertensive blood pressure. According to new American guidelines, the definition of blood pressure is the elevation in blood pressure is a systolic blood pressure between the top numbers 120 and 129 mm of mercury. However, to label a patient as hypertensive, the blood pressure must be persistently elevated, and the diagnosis requires at least 2 separate readings on 2 separate hospital visits. This is to avoid the phenomenon known as white coat hypertension, which is elevation in patient's blood pressure due to anxiety of getting examined by the doctor. Primary hypertension. It is an idiopathic hypertensive disorder with no known secondary cause and is prevalent in 90% of cases. It is mainly due to decreased renal sodium excretion, which results in increased plasma volume due to increased sodium and water reabsorption, resulting in increased systolic blood pressure. The increase in plasma blood volume results in decreased renin formation, leading to decreased renin hypertension. Hence, it is a hypertensive disorder with decreased renin, which is very high yield. In the same case, decreased renal sodium excretion results in increased serum sodium levels, which causes vasoconstriction of peripheral arteries, leading to increased diastolic blood pressure. The risk factors of primary hypertension are age, physical inactivity, obesity, diabetes mellitus, smoking, and family history of hypertension. Secondary hypertension. It is due to some secondary non-cause as renal causes, which includes renal artery stenosis. It may be due to atherosclerotic plaque or fibromuscular dysplasia of renal artery, which results in decreased renal perfusion, leading to activation of RAS or renin-angiotensin-aldosterone system, which in turn results in increased renal sodium and water reabsorption, leading to hypertension. However, unilateral renal artery stenosis does not lead to chronic kidney disease, but bilateral renal artery stenosis results in chronic kidney disease, leading to end-stage renal failure. Similarly, some renal parenchymatous diseases such as glomerulonephritis, polycystic kidney disease, and diabetic nephropathy lead to secondary hypertension. Aortic abnormalities. Coarctation of aorta or narrowing of aorta may lead to hypertension, and it is more prevalent in children. Aging leads to increased systolic hypertension. It is due to increased collagen deposition into aorta, resulting in stiffening of aorta, leading to isolated systolic hypertension, whereas diastolic blood pressure remains normal and it is very high yield. Thyroid disorders. Both hyperthyroidism and hypothyroidism leads to hypertension. The hyperthyroidism results in increased cardiac output, which may result in increased stroke volume, leading to increased systolic blood pressure with normal diastolic blood pressure. Whereas hypothyroidism results in increased renal retention of sodium, resulting in increased peripheral resistance, leading to increased diastolic blood pressure with normal systolic pressure. So, hyperthyroidism causes isolated systolic hypertension, whereas hypothyroidism results in isolated diastolic hypertension. Increased intracranial pressure. It leads to a triad of hypertension, bradycardia, and decreased respiratory activity. The triad is known as Cushing's triad. Pregnancy also includes hypertension as preeclampsia and eclampsia. Some medication, such as oral contraceptive pills, especially estrogen-containing oral contraceptive pills, stimulate hepatic production of angiotensinogen, leading to increased RAS activity. Cocaine results in increased sympathetic activity, leading to hypertensive disorder. Monoamine oxidase inhibitors, which are present in tyramine-containing foods, such as cheese, cause acute hypertension. where the coarctation of aorta or narrowing of aorta is shown, and remember, it is prevalent in children. Where the arteriosclerosis of renal artery is shown, leading to benign nephrosclerosis. It may also lead to atrophy of kidneys, which can be detected by ultrasonography. Chronic hypertension. Chronic hypertension leads to certain disorders, such as cardiac disorders, which result in increased afterload, leading to increased left ventricular hypertrophy, resulting in increased heart stiffness and decreased diastolic relaxation, leading to diastolic heart failure. Risk of coronary artery disease also increases in hypertensive disorders. Similarly, aortic dissection also results, which is characterized by a sharp tearing pain, which may also radiate towards left arm. Intracerebral bleed. Increased blood pressure result in Barry aneurysm or Charcot-Bouchard aneurysms, which are aneurysms of small vessels. Renal disorder. High atherosclerosis of afferent and efferent arterioles results in ischemia of kidney due to decreased renal perfusion and atrophy of kidney, which may be bilateral or unilateral. Hypertensive retinopathy is characterized as dot and dot-shaped hemorrhages, silver copper wiring, and arteriovenous snipping. Here are the findings of hypertensive retinopathy are shown in fundoscopy. The blood-shaped hemorrhages, cotton wool spots, arteriolar narrowing, disc-shaped edema, copper wiring, central exudates, and AV nipping or arteriovenous nipping. Similarly, atherosclerosis of renal arteries is shown. Acute hypertension. An elevation in blood pressure more than 180 by 120 mm of mercury is characterized as acute hypertension, and it is divided into hypertensive urgency and hypertensive emergency. In hypertensive urgency, there is no evidence of end organ damage, whereas evidence of end organ damage is present in hypertensive emergency. The organs such as brain, heart, kidney may fail. In case of brain damage, headache, altered mental sensorium, seizures, papilledema, and strokes are present. Whereas in case of heart, myocardial infarction, acute left ventricular failure, pulmonary edema due to increased sodium and water retention, aortic dissection may also occur. Whereas in case of kidney, acute kidney injury may be evident. Where the malignant hypertension of kidneys has shown the kidney damage. The kidney surface has petechiae, also known as three-bitten kidney, and the fibrinoid necrosis of afferent arterioles are shown. Management and treatment of hypertension. The first choice is to lifestyle modification, which is decreased sodium dietary intake, increase proper exercise, stress reduction therapies such as yoga, and antihypertensive medication, which include ACE inhibitor such as captoprils, ARBs or angiotensin receptor blockers such as losartan, thiazide diuretic, and long-acting calcium channel blockers. The treatment of hypertension with certain comorbidities is depicted. Hypertensive diabetic patient is treated with ACE inhibitors, ARBs, which are protective against diabetic nephropathy, thiazide diuretic, and calcium channel blockers, which are long-acting, such as dihydropyridine. But beta blockers are used with great caution, as they result in increased insulin sensitivity, result in hypoglycemia. So watch out the patient for hypoglycemia. In asthmatic hypertensive patient, ACE inhibitors and cardio and non-selective beta blockers are contraindicated, as ACE inhibitors has adverse effect of causing cough, leading to exacerbation of asthmatic disorder. Whereas non-selective beta blockers have tendency to cause bronchospasm. Hence, cardioselective beta blockers, calcium channel blockers, thiazide diuretics, and angiotensin receptor blockers are used in asthmatic hypertensive patient. Hypertension in pregnancy. The four drugs are mainly used as hydralazine, methyldopa, levetiracetam, and nifedipine, and it is memorized by the mnemonic hypertensive moms love nifedipine. Hypertensive urgency treatment. There is no need to decrease blood pressure acutely in hypertensive urgency, as there is no evidence of end organ damage. Oral antihypertensive medications are used in hypertensive urgency. Whereas in case of hypertensive emergency, the blood pressure need to decrease immediately. And intravenous medicines like nitroprusside and levetiracetam are first line of choice. Hypertension with heart failure. ACE inhibitors, ARBs, thiazide diuretics, aldosterone antagonists, and beta blockers are safe to use. However, calcium channel blockers are contraindicated as they have decreased or negative inotropic effect, leading to exacerbation of chronic cardiac failure, and decompensated heart failure may also lead to death. So, a quick recap. The elevation in blood pressure more than 130/90 for at least 2 consecutive readings is designated as hypertensive blood pressure. Hypertension is divided into primary and secondary hypertension. The primary hypertension, also known as essential hypertension, is idiopathic, and the risk factor includes age, obesity, diabetes mellitus, smoking, and family history. Whereas secondary hypertension has some non-cause, such as renal artery stenosis, coagulation of aorta, certain drugs such as estrogen-containing OCBs, cocaines, or monoamine oxidase inhibitors. Similarly, Conn syndrome. Chronic complications include left ventricular hypertrophy, chronic artery disease, stroke, subarachnoid hemorrhages due to aneurysms, renal failure, hypertensive retinopathy. And the drug therapy contains ACE inhibitors, angiotensin receptor blockers, thiazide diuretic, and long-acting calcium channel blockers. So this is the end of lecture. Thank you.